So in respect for your time, I'm going to go ahead and introduce our two speakers for today for the session Prioritizing Trauma-Informed Care for Veterans. Our first speaker is Aniela Brown. She has over 14 years of experience building relationships, developing communities, and planning events. Wealth of information. Ms. Brown has been a passionate advocate on behalf of trauma-informed practice and open dialogue about healing and resilience. While at the Texas Association of Community Health Centers, Aniela worked to create and facilitate trauma-informed training sessions aimed at supporting behavioral health staff with clinical development and self-care promotion. Our second speaker today is Amy Rachel. Amy joined the Texas Association of Community Health Centers as the Trauma-Informed Care Project Coordinator. She's responsible for coordination of the TAC Trauma-Informed Care Program, curriculum development, and providing training and consultation to health centers on the implementation of trauma-informed care. Amy earned her Bachelor of Social Work at Texas Women's University and obtained her Master's in Social Work from the University of Buffalo. While in Buffalo, Amy worked as a project manager at the Institute on Trauma and Trauma-Informed Care. Please join me in welcoming our speakers today. Thank you, Aniela and Amy.
Thank you. We're so excited to be here with you today to really talk about this topic of trauma and how we can prioritize trauma-informed care for our veterans. Of course, this is Aniela and myself, both TIC clinical coordinators at TAC. Just a little bit about who we are. TAC was formed in 1983 as a private not-for-profit membership association, really committed to advancing equitable access and quality health care in Texas by supporting and advocating for community health centers. You may have heard them called federally qualified health centers, FQHCs, or community centers. In 2019, TAC has been collaborating with these health centers to implement a trauma-informed care program, really as a prevention strategy aimed at creating a lasting change for patients, staffs, and communities. We use a train-the-trainer model. Health center staff are taught via virtual and in-person sessions. We have coaching calls, we have ongoing technical assistance to fully integrate the values associated with trauma-informed care into all aspects of the health center.
So we have nothing to disclose. And this is a little bit more about our abstract for what we submitted for the conference as well. And so let's review our objectives. So by the end of this brief session today, participants should be able to understand trauma and its impact on individuals and communities, particularly for our veterans, recall key components of trauma-informed care, such as language recommendations and key SAMHSA pillars, reflect on the ways TIC can be applied to current dental services for veterans, and really start to think about how you can collaborate with colleagues and patients to prioritize trauma-informed approaches in future dental services. So we encourage you to come off mute or to use the chat. And so if there's anything else you would like us to cover today, please use your chat function, raise your hand, or feel free to unmute throughout the presentation with any questions, although we do have time at the very end for questions as well. So anything else you would like us to cover, please feel free to share. Okay. Okay, so at times the material presented today may be difficult, so we really encourage you take yourself off camera, grab a drink of water, take a deep breath, and just really be mindful of caring for yourself during this content.
So we'll go ahead and get started here. The discussion of trauma-informed care we know is far from exhaustive and a topic that really needs more attention. However, the principles that we're going to briefly discuss today really can begin to provide a framework for incorporating a trauma-informed care lens into your role at your organization and as a dental provider. Acquiring some basic understanding of trauma and utilizing trauma-informed care principles really can allow for both direct patient care providers and those who do not provide direct patient care to not only begin to recognize potential consequences of trauma, but also to see the presence of strength and resilience in that patient. Eventually, the goal is to turn that understanding of trauma into really practical applications that can promote well-being and health, not just for your patients and your families, but also for the healthcare system at large. So really, to define what we're talking about here, trauma is defined as an event or series of events or circumstances experienced or witnessed by individual as physically or emotionally harmful or life-threatening, and has lasting adverse effect on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Traumatic events really could be things like family and social violence, assaults, disasters, predatory violence that confront people with such horror and such threat that it may temporarily or permanently alter one's capacity to cope. It may affect their biological threat perception and even change the way that they view themselves. And so we really want to look at these words here, these we call them the 3 E's that are highlighted in this definition. I also think it's important to remember that we do not get to assign meaning, right, to how something is felt as trauma for somebody. So really, to dive into these 3 E's, when we say trauma, we're really referring to an event or that series of events that occurred, right, and caused that individual to feel threatened or even horrified. So when we focus on events, the event or the circumstance that caused the harm to the individual, this could be a one-time event, or it could be something that's repeated over time. It's important to start with event because this really enables us to decouple the trauma from the individual. When we think about the environment, the event, or the circumstances, it helps us kind of move away from viewing individuals as having a defect, but rather the sum of their experiences. Some questions you may want to know around events are, what was the proximity of the individual to the event? Did it happen to them, to their family, or to their community? And then we think about experience. We want to focus on experience because we know that not everyone will experience a traumatic event in the same way. How the individual labels and really assigns meaning is really how that they're going to perceive that as trauma or not. Questions we may want to ask around this is, did they witness the event? Did they hear about it? Did they experience it themselves? Was the event caused by someone who was supposed to protect them, or was it a stranger? And then lastly, looking at the effects. What are the effects that we can see versus what we can't see? We know that trauma can cause short-term and long-term effects that may not be immediately recognized. The identification of that broad range of potential effects remind us that our response really has to be holistic, not just something that's focusing on symptoms or behaviors, right? So many people may experience really horrendous events without seeming to develop any lasting effects, and others may be affected in their coping responses, their ability to really engage in healthy relationships, or even the mastery of some developmental skills. Our goal is really to support and help restore those individuals through that healing journey. Effects can also be depression, increased aggression, some depersonalization. Trauma can be caused by events that the individual doesn't remember, such as events that maybe occurred early in childhood or even prenatally. Trauma can be caused by experiences that are well-intentioned and necessary, such as medical or dental procedures. Trauma can also be caused by events that did not happen directly to the person, but to a group that they identify closely with, such as slavery, Holocaust, Native American, LGBTQ+ communities.
So in the late 1990s, a weight loss clinic in San Diego, California made a profound discovery. Dr. Vincent Felitti was a medical provider at Kaiser Permanente, and he was approached by the hospital to create a weight loss clinic. He agreed and had instant success with individuals losing 100, 200, 300 pounds. But then he started having those that were the most successful drop out of the program and start to regain the weight that they had lost. The first of many unexpected discoveries was that the majority of the patients who dropped out actually were successfully losing weight. Accidentally, and to the researchers' surprise, they learned that from detailed life interviews of 286 individuals, that childhood abuse was remarkably common, and if present, always was the springboard to the onset of obesity. So for many, obesity was not their problem. It was really the protective solution to the problems they had previously never acknowledged to anyone. So the Adverse Childhood Experiences, or ACEs study, and subsequent research have found a powerful connection that include both physical and mental health outcomes, including the development of chronic diseases and the major causes of adult mortality in the US, alcohol and drug abuse, and the diminishment of lifetime opportunities regarding education, occupation, and income. So for the first time, researchers correlated the bad things that happen to individuals as children with long-term impacts across their lifespan. So there were 10 types of childhood trauma, as you can see on the slide, measured in the original ACEs study. 5 were experienced directly by the individual, and 5 were related to a family member. Each type of trauma counted as 1, and so an individual could have an ACE score between 0 and 10. The important thing to remember is that researchers have consistently found that the higher your ACE score, the higher the likelihood of at least one of those negative health outcomes. And the type of trauma did not factor into the score. So unfortunately, ACEs are highly prevalent. Current data from the CDC show that about 61% of US adults report that they had experienced at least one type of ACE, and nearly 1 in 6 report that they had experienced 4 or more. ACEs affect all communities. So while the original ACEs study was conducted among a population that was mostly white, middle class, employed, college educated, and privately insured, subsequent studies have found higher prevalence rates of ACEs in people experiencing poverty, people from racial and ethnic minority groups, people who are incarcerated, and individuals in the LGBTQ community. So I want to call your attention to those foundational layers of the pyramid, specifically generational embodiment and historical trauma, and social conditions and local context. So we know that trauma can be passed on, and historical trauma impacts populations who have experienced collective, long-term, and widespread adversity across generations. This can look like slavery, segregation, racism, violent colonization, and genocide. These then contribute to the next step up in the pyramid, which refers to the social environment. So these can be chronic and look like community violence, structural oppression, racism, chronic poverty, and forced displacement. So these are the structural, institutionalized systems that affect the well-being of individuals living within them. Now, since the ACEs study was first published in 1998, those involved in this work have advocated for the inclusion of other ACEs to really quantify those experiences that occur in our schools and workplaces, communities, and systems, really those social determinants of health. And they can include experiencing bullying, witnessing violence, experiences of discrimination and racism, involvement in the foster care system, living in poverty, and experiences of deportation and or immigration. So lastly, ACEs are strongly correlated in a dose-response fashion with some of the most common and serious health conditions facing our society today. So we finally have the evidence that what happened to you in childhood really could have a huge impact on quality of life and health outcomes, more than we thought ever before. So in the long term, survivors may engage in behaviors that help them cope with traumatic memories, but that have negative health consequences. For example, trauma survivors may smoke cigarettes, drink alcohol, or overeat to manage those emotional distressors. But these behaviors may provide short-term improvements of their mood. They do have long-term negative consequences for health, including oral health. So of particular note for our active duty military and veterans, I want to call out a few outcomes that have been well documented as being highly correlated with a person's history of childhood trauma, specifically alcohol, tobacco, and other drug addiction, chronic obstructive pulmonary disease and ischemic heart disease, diabetes, lung cancer, obesity, self-regulation and anger management problems, and work problems, including absenteeism, productivity, and on-the-job injury. So as we just shared, exposure to significant childhood adversity affects a daunting portion of children. And research has shown that adverse events demonstrated increased risk of depression, anxiety, aggression, and suicide risk. Adversities tend to be interrelated, creating a layering of stress and exert damage to various aspects of the developing brain. fostering maladaptive health and behavioral habits, and are often really associated with limited protective relationships. So we know that adversity is a process. It's not just what happens in your household, but how society responds to those adversities. But we also know that trauma creates predictable patterns of brain development. And so those things really can impact our attention, our relational health. We see more aggressive behavior, more victimization, and social isolation in this poor understanding of social cues. And as we know, social support is one of the things that really can support healing, yet society tends to respond to adversity in ways that leave individuals feeling isolated.
So just as the original ACE study found a correlation between the exposure to childhood adversity and poor health and social emotional outcomes, subsequent studies have found a similar correlation with oral health outcomes. One study found that those who had an ACE score of 4 or higher are less likely to receive adequate dental care as a child. Another research found that children who reported ACEs were more likely to have poor oral health and significant tooth decay, higher incidence of gum disease, and fungal or viral infections of the mouth. Additionally, having multiple experiences of childhood adversity had a cumulative effect on oral health, meaning those who had more adverse experiences were both more likely to have poor dental health and more individual caries. So when we think about worldview, an individual who's really experienced a lot of trauma will change the way that they view the world. They no longer have trust in people, right? The world is no longer a safe place. A need for self-protection because trauma that they experienced, especially if experienced by someone who's supposed to protect them, right? Now they have to protect themselves. They also kind of will have a loss of hope. And so feelings that nothing will change or there's no point in trying to do something different. So really thinking about worldview when you talk with your patients about trauma and health outcomes.
So now what does this actually look like in our dental practice? So patients with a history of trauma often frequently miss appointments, may be reluctant to discuss health problems, demonstrate confusion or poor memory, have challenges adhering to treatment, may perceive and experience pain differently, avoid services, postpone appointments, cycle in and out of crisis, and delay care until the condition worsens. And staff, since our dental practices are often comprised of staff who may have similar life experiences to our patient populations, staff with a history of trauma often, we see increased absenteeism, high turnover rates, decreased productivity, low morale, increased tension on teams, potential breakdowns in communication, compassion fatigue, and vicarious trauma.
So really, what does this mean for us? We have a little bit of understanding now about trauma and what do we do with it? So for our program, and SAMHSA really looks at the 4 R's of trauma. We work with all of our health centers toward this to really begin to have that real conversation about trauma. We first have to realize that trauma is real and it's pervasive. Trauma is ultimately one of the most important public health issues that we're facing. No one's immune to its effects, right? Traumatic events are very common, as Aniela pointed out in that earlier slide. And then for providers and staff, we have to really begin to recognize what are the signs and symptoms of trauma. We have to learn how to respond when we have individuals who've experienced trauma or maybe demonstrating behaviors at the office or in the dental chair. And lastly, we want to resist re-traumatization through looking at our policies, practices, and procedures. So what is trauma-informed care? Trauma-informed care is really an approach as an organization or as a system that really realizes this impact of trauma and begins to understand what the potential pathways to healing are. Applying these principles to the work that you're doing can really begin to assist individuals that you encounter to start that healing journey. So trauma-informed care is really a strength-based framework. It's grounding in that understanding of and that responsiveness to trauma. It emphasizes physical, psychological, emotional safety for all individuals who've experienced trauma. And it really creates opportunities for individuals to rebuild like a sense of control and empowerment. And looking at these pillars here that SAMHSA has created, really thinking about safety, promoting physical and psychological safety, building trusting relationships with others through transparency, offering choice when possible, collaborating with others, supporting and fostering individual agency through empowerment, providing opportunities for peer support, understanding the role that trauma plays in societies, particularly for communities that have been historically marginalized. Trauma-informed care does not mean that you have to ask patients sensitive or uncomfortable questions, which is often the fear, nor does it mean that a dentist really has to take on the duties of a social worker or psychologist, but rather trauma-informed care is really that framework to help you make the work that you're already doing most impactful. There you go. Many patients who've experienced trauma oftentimes don't seek mental health services, but they'll rather look for help from their primary care. Neither provider or patient may be aware that their current physical complaints or behaviors impacting their health could be connected to past trauma. And when we think about dental patients with a history of trauma or adverse experiences, they're more likely to engage in negative health habits and to display fear of routine dental care. We know that trauma survivors may underuse preventative care for psychological reasons, as psychological factors such as anxiety and depression contribute to those rescheduled, those missed or canceled appointments. In addition to emotional distress, patients may experience psychological reactions when trauma memories are re-triggered. Many oral care visits involve the provider needing to lay the patient back in the chair and restricting the patient's ability to get up from the procedure or the exam. And a dentist may often need to be very close, touching the body, being in very close proximity. So for traumatized patients, this may really be a re-triggering of memories of trauma, depending on the nature of trauma that they have experienced.
So now let's transition to some considerations for you as dental providers when caring for veterans. So as we just discussed, a key pillar of trauma-informed care is historical, cultural, and gender factors. So research and current demographic data shows that our military is the most diverse it has ever been, specifically by race, ethnicity, and gender. So this is incredible news and a point that requires reflection on how we provide trauma-informed care in a number of settings. So with the increased number of female service members, officers, unfortunately, the reports of sexual assault, it's really important for oral health teams to be considerate and provide safety and choice throughout the appointment, like Amy had mentioned, to ensure that our offices remain a place of care and healing, but not re-traumatization. So as the military works to become more supportive of diverse gender identities and transgender service members, oral health providers can model best practice by asking about preferred pronouns, updating health records, and ensuring gender-neutral bathrooms are available. And across the country, we have all heard the long overdue call for racial justice. As we prioritize providing equitable care for our veterans, it is important to state clearly that racism is trauma. And just like reactions to other traumatic events, encounters with racial bias and ethnic discrimination, racism, and hate crimes can cause mental and emotional injury. So oral health professionals play a part in truly and sustainably supporting diversity, equity, and inclusion work for their patients, staff, and communities. So according to a Pew Research study in 2015, approximately 65% of veterans served prior to 9/11, including World War II, Korean conflict, Vietnam, and the Gulf War. So as we discussed at the beginning of our presentation, ACEs are correlated with a number of chronic health conditions in adulthood, and that does not take into consideration traumatic experiences in adulthood, which may contribute to additional and exacerbated challenges. So depending on their experience, trust in systems and society may have been impacted as well. So implementing TIC with all patients, really using a universal trauma precautions approach, but particularly for older veterans, may really significantly impact their engagement with and collaboration in their care with you all as oral health professionals. So one thing to remember is that the experiences of veterans are incredibly varied as well. So according to the same research study, 23% of veterans in 2015 are considered peacetime veterans. So as with all healthcare, practicing patient-centered care, asking questions, and treating each patient as a unique individual will be critical. So lastly, in the case that you also provide dental care to military families, we have a few considerations as well. So asking if there is anything that has changed since the last appointment may prove to be really important. So whether for children or spouses, deployment or family separation and loss, especially on anniversaries of those experiences, may actually impact how a patient responds to your care. So if you know this information, you may be able to better offer more suitable supports and better meet their needs in the office visit. So transitions and moves are also par for the course for many military families as well, but this is destabilizing for building relationships with care teams and therefore make it a bit more difficult to build that trust with you as a provider, which we know is really important for your relationship with your patients.
So what can we do in our practices? Here's some TIC strategies that you consider. Just meeting with the patient prior to the appointment, where the procedure is going to take place. Maybe let them take a visit around the office so they know what to expect. Offering really calming, soothing office environment, avoiding stressful television programming that might be on the TV if you have a TV in your waiting room. Offering to let them listen to music, bringing in headphones might be helpful. Giving as much control and as choice as possible. And this is being flexible about maybe having a support person in the room with them, negotiating the angle of the chair. Maybe they want to wear a coat or some other comfortable clothing. Even thinking about laying the X-ray protector over the patient may assist them in having a little bit of pressure on their body and help their body to relax. Ask if the patient feels safer having the door open, closed, or maybe just slightly ajar. Really validating concerns and express empathy that they're sharing with you during their visit. And again, apply those universal trauma precautions, assuming that everybody that you come in contact with may have had trauma. And so using that universal trauma precaution is a great strategy. And then I want to talk to you just a little bit about this pyramid. Some things that we can do with every patient that comes in is this at the bottom layer here, patient-centered communication. Really specific communication and some behavioral health techniques can help manage patient anxiety and increase the provider rapport with trauma survivors. Just some small changes to practice that can be used with all patients. For example, asking, what can I do to make you more comfortable during this procedure or exam today? If the patient's worried about using a mouth prop, the dentist can explain to the patient that they'll need to keep their mouth open for a longer period of time, and give the patient the opportunity to see and feel the prop before using it. Under the next level up there, understanding health effects of trauma. This is really consists of being aware of and understanding those effects of trauma that we've been talking about today. This does not require the dentist or the team to really delve into that trauma history. It just simply means that the dentist is educated about health-related effects of traumatic events. For an example, when dentists discuss negative coping behaviors with patients, such as smoking, drinking, high intake of sugary food and drink, they should be aware that these behaviors really can be related to those stressful life events. This does not mean that every patient who engages in those behaviors has been traumatized. So approaching patients in a collaborative, non-blaming manner really increases the likelihood that the patient will discuss behavior change and continue to engage in treatment. The next layer up, that third level, collaboration and understanding the professional's role. This really involves collaboration with other professionals and a thorough understanding of the dentist's professional role. Providers should really maintain a list of referral sources for patients, including referral sources specifically for those who disclose a trauma history. Maybe having enough understanding also of mandated reporting requirements that their states have, and should inform those patients when confidentiality really needs to be breached. It is a great trust building. Understanding one's own trauma history. So that's the next level up. And I think this is one that we really have to spend a little bit of time just thinking about for ourselves, is understanding your own trauma history. Some medical and dental care providers may have their own history of childhood or adult abuse. So when providers are themselves survivors of traumatic events, they may feel uncomfortable talking about these issues for fear of really re-triggering or reactivating their own feelings. So it's important for providers to learn empathetic communication skills. Using such skills can really help you to keep from activating yourself and your own memories of trauma. And then lastly, screening. We don't recommend that all dental care providers routinely do screening. Most dental settings do not offer providers time and resources to conduct or discuss the results of screening. Patients also may find that this type of questioning is kind of intrusive when coming from their dental care provider. Yet we have one health center who was able to create a dental anxiety and experience screening that really helped the dentist to understand what type of anxiety or how much anxiety that patients were feeling as they came into their appointment today, and was really able to readjust and use a little bit more empathetic listening when it came to helping their patients feel more comfortable.
So we're sure that you all are familiar with patient-centered language, but we just wanted to provide some more concrete examples of what this could potentially look like. So instead of saying a patient, if you're outside of the healthcare setting, maybe a person, an individual, a member, or a consumer, instead really trying to shift away from not adherent or non-compliant to this patient or this veteran has barriers or often chooses not to engage in care because instead of resistant or refuses, prefers not to or isn't ready for, so that it still is, the door is open for them. Victim or vulnerable is their survivor. So really that strength-based change. A high-risk population is people who are at increased risk for. You alone make decisions, really. So we're switching to it's a collaboration, it's a team approach. So we're in this together, we're a team. Male or female or gendered pronouns, really shifting to partners or folks or people, or really, like we had mentioned, taking into consideration the preferred pronouns for individuals as they come through and really making that highly specialized to that individual. Underserved or the uninsured, people who are medically underserved. And then really at the core of trauma-informed care is a shift from a question of what's wrong with you, what's wrong with this community, what's wrong with this population, to what happened to you. And so it can be applied to the individual or at a community or a societal level.
We know that each dental office is different and will be starting at different places. We acknowledge the diversity of experiences that we have in the room today, and we want you to know the various levels to this trauma-informed care process. Today might be the first time that you're becoming trauma aware. So this is really establishing awareness of the prevalence of trauma and its effect on staff and patient. It's really getting this basic awareness of maybe what signs and symptoms and pervasiveness of trauma may look like, and really beginning to discuss what is trauma-informed care and how can we bring it to our office. Our next level is trauma sensitive. This is where your staff really start to explore those principles of trauma-informed care and consider how they may implement those principles within their work. Next, you have trauma responsive. So this is where you begin to see a change at all levels of your organization. You're looking at policies, practices, procedures, and really trying to engulf that trauma-informed care language that Aniela just demonstrated for us. And then lastly, trauma-informed. This is a full implementation of trauma-informed practices. There's a culture of trauma-informed care that can be seen in responses between staff, interactions with colleagues, and with patients. And just to recap, we want to make sure you remember those 3 E's: the event, the experience, and the effect, and those 4 R's, really realizing, that trauma is pervasive, recognizing signs and symptoms, responding to those, and then thinking about re-traumatization that could happen within our offices. Those acronyms will really help you remember this information and help you to start really thinking about how you can add this into your practice. We also want to acknowledge that this process takes time. The TAC-TIC program supports health centers throughout the organization-wide transformation, but it does not happen overnight. We sincerely really appreciate this opportunity that you've given us to speak with you all today, and really look forward to continuing our conversation about trauma and a trauma-informed dental practice. We've, on the next slide here, we have a few resources for you. The last one, Dr. Sharon Zaks out of Australia, has some really great videos from patients that I think that you might find very helpful too. And then of course, our bibliography. And then if you have any questions, we would love to answer anything for you or clarify anything that we spoke about today. Yes, Angela.
Good morning, everyone, or I guess it's afternoon now. Thank you all for an awesome presentation, and it's more of a comment. I just wanted to share how important, of course, this is. And in years past, I worked in Texas. I'm in Mississippi now, but when I was in Texas, I did work for a community health center. And while at that time, not a lot of work had been done around, trauma-informed care, I did notice at the time that we had a lot of patients who came in with triggers that impacted their dental work. And I was fortunate at the time to work for a community health center that had a psychiatrist, and then she left, and then we got behavioral therapists. But one of the things that we really work towards, or we're working towards, is to be able to incorporate a level of screening, depression screening into, because that's one of the things that I think as a dental clinician that is lacking as far as social assessments. Mm-hmm. We do the medical history, but most of the time with our social assessments, that's not embedded in the practice in the electronic health record. And so one of the things that was helpful was really working with our medical team to say, hey, we need to embed this into dental, or have a triage process, which we really established first, where if we had a patient that, experienced a trigger, or we figured something was going on that was hindering the dental work, is that, we had a lifeline with our behavioral therapists. And fortunate we were able to have them on site so many days a week, and we're able to utilize them in this way to assist with those areas. The other thing that came to mind was, you talked a little bit about integration as far as people being able to trust the provider to go over more in-depth information about their history. And I would just lean to say that sometimes we don't consider chronic disease diagnosis as a trigger. And in one situation, we had a patient who had a recent diagnosis of HIV that was impeding his dental work because he didn't feel the dental team needed to know, and he was seeing the medical team. So there are all these little areas and hot spots where this information is so useful, and we had to work collaboratively to help him understand the significance of a shared team in the approach. But there were also things we had to do internally as an organization to make sure that systems embrace this level of care that was needed. So thank you so much for bringing this to everybody's attention.
Yes, thank you for great examples too of how you are incorporating that integrated care, for sure.
Yeah. Amy, do you want to share actually the example of what that actually looked like, the screening process that you had mentioned in the presentation at the health center?
Yeah, sure. So the dentists really, as we said at the start of this, are kind of left out of the loop of trauma-informed care and having that integrated care. So through our program, one of our behavioral health specialists reached out to the dental department, and they created this screener. Within the first 90 days of that screening, they actually came across 3 patients who were suicidal with a plan, and they were able to get them into inpatient care and some extended daycare to help those patients. And within that 90 days had like 45 referrals to behavioral health. So then their behavioral health became part of their team and helps patients who say, I'm pretty fearful of the dentist today. They'll work with them doing some coping skills to make sure that that patient can make it through their treatment. And so it's been really incredible to see the work that's been coming out of the health centers and really integrating behavioral health with dentistry for sure.
Other questions?
I think we're at our time here. Oh, Jasmine, were you gonna?
Yes, thank you so much, Anila and Amy, for your time with us today and for sharing such a powerful and informative presentation. And thanks to everyone that was able to join as well. I just want to provide the CE code for today's session. It's TIC 216 VET. Again, that's TIC 216 VET.